My name is Amy Royer. I am the project coordinator of the Rural Health Initiative. The mission of RHI is to engage partners to share ideas and expertise and to support communities improving health while stimulating a higher level of wellness across the state. Thank you for joining us for our webinar today, Age-Friendly Health Systems. It's presented today by Geriatrician and Palliative Care physician Kathryn Borgenicht, and she is the medical director of Hospice.
Hi, everybody. This is all such a amazing thing to do these things by video. I've actually learned how to do them at this point. So I am actually very excited about this topic. And let me just back up for a moment. Health and aging, age-friendly health system, question mark, common sense. And the other thing I was thinking of as I was preparing this is really, this is a very creative part of medicine. I first got introduced to this a couple of years ago at the American Geriatric Society when the Institute for Health Improvement brought this out. And I'll make sure you have the resources. Some of them are listed in here, but I'll make sure by the end that you get them. Um, the just the and then I went to a 2-day conference about it in Utah at one of the ski resorts. So I've now condensed everything that I learned in 2 days to this 45-minute talk. So there's a lot of material in here. And what I was talking with Amy about earlier is if people are interested in pursuing this further, I'm more than happy to have a conversation with people. This is my email. I will respond to it, and at the end, we'll go through that again. So what makes this so important? First of all, health and aging is not healthy aging. We're very used to the paradigm of healthy aging. How are we going to stay healthy for the rest of our lives until we drop dead or whatever we're going to do? But this is really not that. We are going to age. This is how do we maintain our health while we're aging? So a couple of things. The leading cause of death now in the world is multiple chronic conditions. And I think all of us who work in geriatrics are aware of that. The life expectancy, and I have a graph that I'll show you in a minute, in the US is on par with Cuba. Every other major industrial country is higher than us except Cyprus, Ireland, and Portugal. However, and I'll show you this graph in a moment, which is not the best rendition because I had to snapshot it and put it in, but we spend more money per capita on healthcare than any other country, and yet we're one of the lowest in terms of life expectancy. So you can see this on the graph. We are circled down at the bottom: United States, Cuba, Ireland, Portugal, and I can't read the other one, but look at how much more money we're spending. And I think the COVID virus has really brought out some of that. So why do we think this is happening? And this is part of my palliative care and geriatric bent. What we've done is put disease at the center rather than the person at the center. And it should be what matters to you is what is the matter with you. And I think those of you who heard my earlier talk in April about advanced care planning, I talked about that also. I've had this interesting experience lately where I've working with the Community Coalition Group, and they have, the Mountain Pacific has gotten a certain amount of money from Medicaid, CMS, to help us with all of this and coming up with projects that we might do. And it struck me as how incredibly disease-centered all of these things were, as opposed to really centered around the person. So why should health systems want to be age-friendly? What's in it for them? The only big data letters I care about are the 4 M's: make me more money. So if you do pull up the Institute for Health Improvement, the business case plan for becoming an age-friendly health system, they'll go through this in much more detail than I will. But just briefly, these are some of the things that you can go to the C-suite and talk to them about. And we know all this stuff, but we really need to get administration and people in the C-suite on board about it. So we know that in the various projects that have gone on, that it reduces costs associated with poor quality care. We know that it supports bundled payments. Any of you who are involved with bundled payments, it really helps with improving transitions, improving people coming back and forth to the hospital. It improves increased utilization of cost-effective services so that we're not just spending money on services, we're actually looking at why are we doing it. And in some ways, it's enhanced revenue and has enhanced market share. Again, I'm not going to go into the whole part of this, but I think there are, if you go to that business case, it will help you come up with some ideas. So what I want to spend most of the time talking about is what it looks like and give you some examples of some ways that in all settings you might be able to apply it. As I said, it needs to be applied in multiple settings. You need to assess your own setting. Don't say, oh my God, I'm going to do all 5 of these things, but see what might work within your setting. Okay, so I'm going to, throughout this talk, I'm going to talk about Dr. L. This is a 78-year-old retired pediatrician who has Parkinsonism, coronary artery disease, and a long-standing history of depression. Most recently has had some increased problems with swallowing, with 1 episode of choking. Took him about an hour to recover from that. He also had a recent fall off his electric bike, which resulted in a road rash and a bruise to his shoulder. He lives with his very caring wife, who watches him closely. He has family that lives nearby. He takes 8 different medicines and multiple vitamins. So throughout this talk, I'm going to come back to Dr. L. We fondly call him Dr. Lou, and ask some questions about it. So these are the 5 M's, okay? And again, I put up at top the Institute of Healthcare Improvement, which is where this came from. They did a lot of different research studies and did a lot of focus groups to come up with these things. So the first thing is what matters. Then medications, mobility, mentation, and multiple morbidities. So I'm going to go through each of these and try to give you some idea of how to focus in on them. Okay, so my talk in April was all about, what matters in advanced care planning. So for this talk, I'm not going to go through all of those, but I do want to address this issue of so little time. I find that really concerning, because if we don't have time to do this, and certainly COVID, I think, has brought this to the forefront, I'm not sure what else we're doing. I think we really need to put this up front, as opposed to what is your hemoglobin A1C, what is your blood pressure. All of that falls under under what matters. So again, pick one. I have a particular, I particularly like prepareforyourcare.org. People have heard me talk about this before. At Bozeman Health, we're using it. I think various sites across Montana are using it. It's very user-friendly. They actually have a whole section now on COVID and how to have conversations about what matters through telehealth. And you can just get online. These are all free. It's great. So ultimately, it creates a document. I think one thing that I've stressed with most of my talks is that preparing for your care and advanced care planning is not about the document. It's about the conversation. The document comes at the end of it, but you gotta have that conversation first. With COVID, it's even more important. I was on the phone yesterday with some people from Bozeman Health on the med-surg floor, and they were talking about how incredibly helpful it would be if people really had that conversation and it wasn't just a document. I put down the Palliative Care Wisconsin website for resources around COVID. I put that in my last talk. It remains one of the best sites for for getting anything that you might want around how to have conversations about COVID through telehealth. Okay, so Mary Tinetti, I don't know how many of you on the call are familiar with her. She's somebody that I was, has been around ever since I did my fellowship in geriatrics. She's sort of the queen of fall prevention. She did this wonderful talk on a website called GeriPal. It's a blog, and I would recommend subscribing to GeriPal because they have just some wonderful things on there. Her particular talk was quite remarkable. And I would highly recommend it. Here's what she talked about, though, and she didn't, instead of calling it advanced care planning, she called it current care planning. And it was just fascinating to listen to her talk. I love these brilliant geriatricians. I don't necessarily consider myself one of them, but it was just brilliant how they have reframed things. So so what she did, and because it's current, it's about how that person is right now, not advanced care planning, but right now. So identify patients' priorities. What outcomes do they want from their health? And there were 4 areas that she asked patients to stress: functioning and autonomy, relationships and community, managing your health, meaningful things in your life. I think we all could actually look at that and say, okay, these are the things that really matter to me. And it may not be your blood pressure, it may not be your diabetes, it may not be your cholesterol number. It may be, I want to be able to walk down to the end of my driveway without any pain in my knee. Or it may be, I want to see my daughter who is in California and I don't know when I'm going to see her. Those are the kind of things that I think really we need to be looking at. She suggests starting with one goal and using the patient's own outcomes and preferences rather than their disease. So what does the patient want to get out of this? And I have a couple of examples of this in the next couple of slides. And then focus on function, not necessarily symptoms. We've learned this, those of us who do any pain management have learned how important the focus on function is, as opposed to just focusing on symptoms. Okay? That has become now sort of the gold standard of how you take care of patients when they have pain. How do you want to improve your function? So what she does is she really drilled down and got very specific and said, okay, if you're having trouble walking to the end of your driveway, what is the thing that is keeping you from doing that? What then medically can we help you with? And are there other activities that might match up with what you are doing? So at this conference, and I don't remember all the details about it, they were talking about this man who was a soccer coach, actually. And as he got medically more complicated and had more loss of function, he modified what he was doing. So he was still able to participate some way in soccer, but he couldn't quite do it the way he had. The other thing that she talked about is that this can be done by a trained facilitator. So you can train a nurse, you could train a medical assistant to really drill down on these things and then bring it to the provider and say, this is what I've found out. So one of the examples that she used is, what do you most want us to focus on? Fill in the health problem so that you can do whatever the activity is more often and more easily. It's always a little frustrating to me because I feel like I'm talking to myself here. So I'm much more used to having an audience interaction, but we'll go where we can with it. So this is one of the examples that I really liked. So this is about Buster. So, statement A, you have been in and out of detox 6 times in the last year. You aren't following through with your appointments. You better stop drinking or you will die. Statement B, however, is they've identified that their dog Buster is the most important thing. I know he gives you a reason to keep going. Where does he go when you are in the hospital? What do you say we talk about ways to stay out of the hospital so you can take care of Buster? What ideas do you have about that? Just a whole different way of approaching that patient and what has been going on with them, and trying to focus on what really matters to that patient, and also to say, tell me what you think. Tell me what you think will work. Okay. And I'd like to open up the chat a little bit on this one. So Dr. Liu, when asked about his living will by his physician sister, he states, yes, I have one, and I've discussed it with my wife. My kids know about it, but do not know where it is. I've not looked at it for probably 10 years. What advice would you give him? So here's a guy who has multiple physician visits. He has a neurologist, he has a cardiologist, he has a GI specialist, he has a primary care doc. And yet nobody has talked to him about this. So again, anybody out there want to say what you do with him other than hit him over the head from his sister? Linda says, have another discussion about what matters. Thank you, Linda. And the other thing that we know is that it would be good if he brought this to his physicians. Okay? But he also needs to have another discussion with his wife and probably talk about it with his kids. One of the big things that we find with advanced care planning is that we don't talk about it with everybody. So all of a sudden, this living will or advance directive appears, and the son or the daughter says, I didn't know anything about that. I don't agree with that. Okay. So let's talk about medications. This is actually a huge area. And there's a lot of talk about it in the hospice world because we are constantly having to go through patients' lists and modify what they're taking for a whole variety of reasons. My main source for this actually is Mary, where's my stuff? Mary Lynn McPherson, who's this amazing pharmacist out in Maryland, who does a bunch of stuff about medications and what people should be taking, what they shouldn't be taking. So I want to go through a couple of these things and then show you a few things. So medication reconciliation, this is a particular concern to me because when I was working in the clinic, I found routinely that we really weren't doing med reconciliation, that it really was just a checklist. You're taking this, you're taking this, you're taking this, you're taking this. Nobody was actually looking at these meds and saying, why are you taking this? And I often, when I would ask people about it, they would say, oh, my doctor said I had to take this for forever. This would be a 95-year-old person who was on a statin, my particular bugaboo for me. And so having a conversation with him about that he probably did not need that statin, could take most of the appointment, which is why I think we're not really doing good med reconciliation. It's complicated because we have patients that go from the hospital to the nursing home to the home or to assisted living, and each time we need to look at those medications and make sure they're really appropriate. I think with medications, we have to evaluate patients' goals related to life expectancy and adjust meds for that. Patients with dementia have very different goals and life expectancies than a healthy 85-year-old. We need to evaluate meds for potentially inappropriate meds, which are all over the place. My favorite one these days is Colace. My hospice team has heard me talk about this all the time. Colace is actually not worth it, but patients all the time are given Colace, and there's lots of advertising about how great Colace is. It doesn't work. Deprescribing, and I'm going to go through a couple of examples of how you might do this. Deprescribing, it can take time. It's not just a matter of let's stop this, this, and this. You've really got to have it. It's got to be a conversation. And then when I was at this conference in Salt Lake, they did the most wonderful practical thing for patients who were in the hospital. It involved having an occupational therapist and a pharmacist. And so they would go in, the occupational therapist would go in and do a test on that patient where he said, okay, show me how you're going to take a medicine if it's ordered 3 times a day, if it's ordered 3 times a week, if it's ordered 3 times, if it's ordered once a day. He had a whole little scenario on it. And, people who said I have no trouble with their medications invariably would start having trouble with their medications. They could not fill out a pill box appropriately. So that gave a cue to the pharmacist to come back in and do a different kind of education. It was such a simple intervention. And if people are interested, I can in a follow-up call, we could talk about it. It was such a simple intervention, and yet it really showed a lot of problems that people were having. One thing on the I will be talking about in a little later about the adult wellness visit. And one of the questions is, do you have any problems taking your prescription medicines? Well, no, I don't. Well, actually you do, and so let's talk about it. So deprescribing, let's talk about that for a few minutes. So this is, again, comes from Mary Lynn McPherson. She does this medication deprescribing, 1, 2, 3 ABC. What's the purpose of the medicine? How is the patient using it? Are they using it correctly? And how's that working for you? So not to pick on Dr. Liu, but he's on a lot of medicines, which you'll see later. But one of his statements to his neurologist, when the neurologist asked him how his Parkinson's meds were working, he said, well, I don't know. I don't pay any attention to it. Now, that's good. That's probably good because it's not a problem for him. But on the one hand, on the other hand, it's good to know that a medicine is actually working for you. So then the ABC is, have there been any adverse effects? What's the benefits and burdens of that medicine? We don't often talk about that. The drugs that are out there for dementia have limited benefit and probably have more burden than we think. And then it's a conversation. All of these require a conversation, which I know is time consuming, but it's so key. So I don't know how many of you are familiar with the SPIKE protocol. This is something that's used by a lot of residents in the hospital to talk about giving bad news. Mary McPherson talks about it as you can use it for talking about medications. So you have a setting. So who are you talking with? You're talking with the patient, the family, the person who's giving the medicines, whomever, and you're sitting down. What is their perception of the meds? Okay. And then invitation is really, is it okay to discuss this? Because if it's not, then do something else. What do you know about the meds? What do I as a provider know about the meds? We went to medical school for a reason. And so we do know certain things about these medications. But if we don't know, for example, up in perception, that the person was told, I have to take this inhaler because it's what's keeping me from getting short of breath, but they're not really noticing any effect, I won't know if I go down to knowledge how to talk about that. Then you have to talk about, if these things bring up emotion for people. Summarize recommendations, and what we found in hospice is that we have to repeat this. We have to go over it again and again and again, and it takes a while for our patients to say, and families more than patients, to say they're ready to give up these medicines. And we're not just talking giving up medicines. I want to backtrack on that a little bit. We're talking about really going through medicines and saying what matters and what's important. So here's Dr. Liu. He takes 8 different medicines: lithium, citalopram, metoprolol, rosuvastatin, Sinemet, ropinirole, mirtazapine, and Ritalin. His wife gives him a handful of vitamins in the AM. As I said, he'd seen his neurologist, who queried whether he had noticed any difference from his meds. What would you like to make sure you do when you visit with him, and how would you address his recent choking episode? So 2 different questions there. And we can talk about that now or later. I personally would certainly want to know what is the purpose of all of those medicines, and what would happen if we tried to back off on any of them. I would also really want to know what vitamins he's taking. I personally am not a big vitamin person. I don't necessarily think they're all that useful, but I do want to know what people are taking. And then in terms of his recent choking episode, at some point, my concern would be, this is a lot of medicines, and how might they bring on another choking episode, and what would we do then? Okay. This was another piece that I thought was really fun, which was about mobility. And these are some of the things to think about. Think about a patient in the hospital, and I'm going to come back up to that. Think about PT, physical therapy, Medicare rules. Think COVID and delirium, and think that mobility increases the risk of death. Loss of mobility increases the risk of death, hospitalization, falls, and declining functional status. So let's go back up to the patient in the hospital. You have this patient in the hospital. They're lying in their bed. They may have an IV in. They may have a Foley catheter in. They may have monitors on. They may have a pulse ox on. They may have a bed alarm on. They may have maybe one chair in the room, and they've got a TV and they have a remote control. Is there any reason for that person to try to get up out of bed? I can tell you right now, there is no, and they bring them their food. So there's no reason why this person would want to even get out of bed. And we know that decreased mobility is a big risk factor for patients when they're in the hospital. There's a recent GeriPal blog about the alarms that they put on people and sitters that they use for fall risks, okay, for patients when they're in the hospital. They looked at a whole bunch of different studies, and they basically found sitters did not help prevent falls. In addition, those alarms that they put on you, they found do not help prevent falls. One of the geriatricians on this blog said actually they were looking for an alarm that went off if the patient didn't move, which I thought was actually a great thing. So to really pay some attention to what a patient is doing in the hospital. There was a intervention that I will be talking about, in which they really looked at how to improve mobility in the hospital. Again, they did it with trained volunteers. Physical therapy Medicare rules, I just want to bring that up because for those of you who don't know, Medicare has now said when you are getting physical therapy, you can only have 45 minutes. Now, in my opinion, that makes no sense. People who are on Medicare need physical therapy probably more than the healthy 50-year-old who's going under a knee, who needs physical therapy for a knee replacement. That person gets an entire hour. The person who may have some cognitive impairment, has broken their hip, gets 45 minutes. Just a little thing that I find really concerning. Think about COVID and delirium, and I'll have a little bit more about this later. There is an article by Sharon Inouye, who's also a geriatrician, who did all incredible work around delirium, and her concern about the lack of visitation in the hospital, the lack of volunteers that can come into the hospital to help patients with their delirium. And she talks about how there's been a big spike in the use of restraints and the use of antipsychotics because people have not been able to have visitors. And she talks about family as being essential workers. It's an interesting concept. Okay, so mobility can be complex for all of us because it involves all of the above: balance, medications, sensory issues, blindness and deafness, footwear, what do they have on their feet, the environment, and how are they functioning. So it's very complicated. It's not just, well, let's get rid of some meds. Everything feeds into each other. Clinical tool to use is, I think, the timed get up and go. You have a person get up from the chair, which gives you lots of information. Have them walk to the door and have them come back, and you can time it. You can find it online. It's really easy to use. It takes probably 15 seconds. And then you need to be able to communicate. So how do you really want this person to function? What kind of things do you want physical therapy to go in and do? Home health? What are the kind of things they should be looking at? Back to Dr. Liu. So after his recent falls, he is concerned about getting on a bike again. He continues to participate in various Parkinson's mobility classes, including Pilates, boxing, and dance, although some of this has been restricted by COVID. How would you approach his recent fall and his desire to continue to ride his bike? So again, something to be thinking about. When I have talked, he now has a local park near him, and instead of going for a 10-mile bike ride, he may go for a 4-mile bike ride, but that still would allow him to get out. Okay. So when you get to mentation, here are the big three: depression, dementia, and delirium. So here's the problem. Each of these deserve a separate discussion. Each of them interact with each other, and all have underdiagnosis, underprevention, and undertreatment. So when I say that, it is fascinating to me when I look at problem lists on patients and you don't have a diagnosis of dementia, even though it's clear that person has dementia. It just doesn't, nobody thinks to put it on the problem list. You may have a diagnosis of depression, but whether it's really been treated or not is not always clear. And delirium invariably gets counted as encephalopathy. Delirium in itself is a diagnosis, and I think we need to make sure that we put it in and that we have it. Under prevention, so primarily around under prevention, I don't think there's a lot that you can do to prevent dementia, but I think there's a fair amount that you can do both in the hospital and in assisted livings to prevent delirium, and I'll talk about a little bit of that. And I think that also depression, you can do a lot of prevention with some of the same techniques you use for preventing delirium. And then there are some really good medicines out there. Now, Dr. Liu, as you noticed, was on four, I think it was four antidepressants. He has been, his depression has been very stable for a number of years. So there is some real concern. You may look at it as a new doctor and say, oh my God, I have to do something about this. On the one hand, on the other hand, he's been stable for a long time, and he had a very significant depressive episode. So Sharon Inouye, let's talk about her for a few moments. She is a delirium queen and has been the delirium queen for years, probably 30 years, 40 years, wrote some of the seminal studies about delirium. These are some of the predisposing conditions: cognitive impairment, severe illness, visual or auditory impairment, all of which happen in the hospital all the time, and then hospital-acquired conditions, medications, procedures, bed rest. So she developed this program called the Hospital Elder Life Program. Again, you can look it up. And she had a team, again, of trained volunteers. And this is what their intervention was. It was really this is where I get back to the common sense and to the creativity of medicine. So, daily visitor program, targeted activities, early mobilization. Okay? People in the hospital needs to be in order, along with the daily, checking of the glucose or the blood pressure, out of bed 3 times a day and walking. That needs to be an order that we are doing, and not just having physical therapy coming in and doing range of motion, but you can get somebody in there to help with mobilization. Feeding assistance. How many of us has gone into the hospital, the assisted living, the nursing home, and there's a plate of food, and nobody's around to help them eat? The nursing homes are actually pretty good about that. Hearing and vision protocol. The bells and whistles that go off in the hospital are extraordinary. And if I were hearing impaired, I think it would be really difficult for me, and vision impaired. Glasses are sometimes, in the drawer next to the patient, but the patient can't get to it because they may have an IV in that hand, and so they don't want to move to get their glasses. Non-pharmacological sleep protocols, so a soothing environment, music, herbal tea, hand and foot massage. One caveat on that is we did have a patient at one of the nursing homes who wanted hand and foot and other things massaged when they went to bed. So that was not really the best protocol. But these are all very simple things. You don't need a physician to do these. You need some help from the rest of the staff and not just nursing. Nursing's, in my experience in the nursing home and in the clinics and in the hospital, is that nurses are so task-oriented that it becomes really somewhat difficult. Back to Dr. Liu. I meant physical therapy Medicare, yes. The question was, did I mean PT Medicare? Yes. On questioning, he's been on multiple psychiatric meds for years. He's not willing to change them. His wife and children have expressed concern about his memory, although he denies any issues. He remains an active reader and is very socially engaged. Would you change anything at this time? Any thoughts? So I would not. I think that this person, who I know very well, is doing quite well, but I would go back up to where we started and say to him, okay, if we were to change anything, what would you change? And maybe he would say, there's nothing I want to change right now. I'm doing fine. So multiple diagnoses, really, it's back to all of the above, and you're not just treating one disease, but you are treating one person. So I want to give you a couple of examples of what we had at the from Salt Lake City. So one of the things is really focusing in on transitions, and we are trying to do that in the Bozeman community. It's actually an enormous project, because getting everybody at the table, which I think we've started to do, is great. But then having all these different providers, knowing what each person is talking about, making sure there's good med reconciliation, really knowing what the home environment is, knowing when and if somebody should be on hospice. These are all, none of these transitions are really seamless. And so there are a bunch of different programs out in the community that are using actually palliative medicine to try to look at some of these transitions and how to make them better. But I don't think you can get around clear communication and just talking to people and where they are. That's got to be the core of any of this stuff. And then the University of Utah has done something really interesting a bit around their annual wellness visit. So let me just say that I was not, when I was in practice, when I was in primary care practice, was not a big fan of the annual wellness visit. And I still have some questions about it. The primary care likes it because it's a lot of money, and that's a good thing. Back up to the, what is hospitals like? What do organizations like? They like money. So I think that there are ways of doing the annual wellness visit that may be more useful than what we are doing. Most of the time it is a checklist. But I think if we really focused in on things like the mentation, what are people thinking, really do a good reconciliation. Really look at the meds and get rid of the ones that are, they shouldn't be on, or that they're really not taking. Not just clicking the box and saying, I know they're taking all of these medicines, I've asked them. Instead saying, let's talk about how you're taking these medicines, and let's talk about what you know about these medicines, not just clicking the box. Okay. Mobility, and again, goes back up to that question that I saw on our adult wellness visit was, so, any problem taking your medicines? That does not get down to what's really going on. Mobility. So I cannot remember a note, other than from occupational therapy, where I've seen anybody really put down in a note, what are their activities of daily living that they can do? What are their independent activities of daily living? Where is the time get up and go? So really having a spot in the note that really addresses that, so you can look back at it. I'm not sure, no offense to medical records, to electronic medical records, that they've really helped us with this. Finding that information is difficult. And then again, what matters? So some of the practitioners do it really well and actually have a conversation with people. But I can tell you that there are a lot of providers who say, oh, yes, they have an advanced directive, it's in the chart. And that's as far as it goes. That is not really addressing what matters. So I think there is an opportunity with the annual wellness visit for us to be doing better, and they've certainly found that at the University of Utah. Okay, finally, the rest of Dr. Liu, he remains very active, very aware of his multiple medical problems and how they affect his daily life. He decided to give up driving 6 months ago. He continues to play tennis with his brother, but has adapted his style to fit his mobility needs. My understanding is that his brother just hits directly to him. He is an avid fisherman, but now makes sure he does not go alone. And another one of my favorite people, Atul Gawande. We've been wrong about what our job is in medicine. We think our job is to ensure health and survival, but really it is larger than that. It's to enable well-being. And well-being is about the reasons one wishes to be alive. Okay. So here's some of my reasons. My son, my daughter, and my son-in-law. And this is Highlight Canyon in the winter. So I am going to try to find chat on here. We have about 10 minutes. Oh, come on. I can't find my chat box. It'll pop up randomly, I'm sure. But I would love to answer any questions. I would love to, if people are interested in further dialogue, I would be happy to set up a little ad hoc group to talk about it. And I'm looking for my chat. Linda, Amy, can you read off any chats to me?
Yes, so we have one question from Linda. So how long could this model be used in, say, an assisted living setting?
Well, I think it depends on which part of it you're going to use. But I think for me, one of the pieces in the assisted living setting might be, okay, let's check and see who has an advanced directive. Not necessarily Pulse, but who has an advanced directive, who wants to have a conversation about it, who's the family. You know, that to me in the assisted living would be great. You know, to set up some kind of project like that. We could also, you know, it's hard with the COVID virus now, but, you know, really talking to the activity directors about what they're doing around helping people with their mobility. And I think there's so much opportunity out there to come up with little different projects that I think be really fun. Truth in Advertising, Dr. Lou happens to be my brother. And he's a remarkable example of somebody who is really doing health and aging. I am going to get on him about his advanced directives.
We had another comment. It just says, great presentation, so value your time and your commitment to enhancing the lives of others. And then another one just came in. It was sent to me privately, so I'll share it and then I'll go ahead and read it.
Okay.
So much of what you have covered is about using motivational interviewing,
True.
which would be great to have in a medical and nursing care curriculum now. This is a great presentation and hope many providers take the opportunity to watch.
Yeah, thank you. You know, we did some motivational interviewing training at the hospital, and I didn't quite get it. But this is about motivational interviewing. There's no question about it. It's about what really matters to you, and what can we do to help you with that. So I appreciate that. And again, if you want to talk further about this, this just excites me, this stuff. I just think it's really interesting. And we want to set up a little, you know, ad hoc group to talk it through some more. I'd be happy to do that.
Kathryn, I'm going to share your email in the chat. Oh, look.
Great.
Oh, there's another comment that just came in. Can you read that, Kathryn, or no?
From Linda?
Yes.
It is an interesting, you better read it to me.
Okay.
Anyway.
No worries. It is an interest to many clinics to try to become age-friendly, and some are looking at using Medicare annual wellness visits to get the 4 or 5 M's.
Right.
Have any of your clinics in Bozeman accomplished this?
No. But I have a great thing from the University of Utah about that. And Amy, and Linda, we could certainly share it. I know you're not coming to Bozeman anytime soon, but maybe we could set up a time to in person to share that. You know, they're doing it at the University of Utah, and I think it'd be a great thing for us to try to do in some of the clinics here. So Linda, we'll be in touch.
Yes, and if you have any resources from the University of Utah, kind of how they're accomplishing that, I'd love to share those resources as
Yeah,
well.
I'll have to look that up again. I had some and then I don't know what I've done with them, but I will, I'll get in touch with them. I know how to get in touch with them. So,
Excellent. Yeah, that'd be great.
yeah.
Terry said, how do we get primary care clinics to be interested in becoming age friendly?
Oh, I think that's a great question. I think part of what you do is what I would do if I were part of a primary care clinic is I would really um, try to get a little subgroup together and start looking at the material and say which of this can we do, you know, you know, take one piece of it. Don't, you don't want to take all of it at one time. So just really try to find one part of it that might really people could grab onto. It may be medications, I don't know, or it may be just reviewing, making sure that advanced directives are being reviewed. Um, I don't know, but I would pick one thing at a time. I wouldn't try to do all of it and see who you can get interested. I think you would want, like 3 people. If you can get one provider involved who and I'm happy to if you have a clinic, I'm happy to talk with them and go through some of this stuff with them. That would be really fun. But I think you got to take it one piece at a time. The other thing is I would really recommend that you get onto the Institute for Health Improvement website and go to the business plan, and they have some really good suggestions in there.
We have another comment from Linda. It says, we feel with homebound status being lifted during COVID, then OT consult would be awesome to peek inside someone's home and get a look at mobility concerns.
Right.
Do you see homebound status going back into effect anytime soon? It has been such a benefit to elders to have this care provided OT, PT, ST nurses during this time due to their age and comorbid conditions.
Yeah. I think, unfortunately, hopefully not in Montana. That won't come back, and we can keep our incidence of COVID down. I am, I think one of the issues we're facing in Bozeman is that each assisted living is doing things a little differently, and some are not letting OT and PT in. Um, I'm glad that they are in Billings, and we're working on having some consistency here in Bozeman, but it's been a little tough.
Okay, we've got another comment. Has written, I had a question about the resource for the limited time of 45 minutes for PT covered by Medicare. Is this setting specific?
Nope. Physical therapists have 45 minutes with Medicare patients, and I can speak about that personally because I had to recently switch my insurance over to Medicare with a supplement. And I will tell you that the physical therapist that I went to, out of those 45 minutes, had to spend 20 to 25 minutes filling out a huge list of questions on me. Those are the regulations. This particular physical therapy group, when they were audited by Medicare, was told that they were spending too much time with their Medicare patients. So I think it's across the board. I think it's CMS, and it's really not well thought through.
Another comment, traditionally health service research focuses on financial incentives and disincentives to change physician behavior. I find that this focus is limiting and insulting. Can you speak to that issue as related to the last question about motivating primary care practices to become age friendly?
Yeah. It's a big problem. As I think many of you know, that the electronic medical record is not said to be patient friendly. It's around how do you maximize your billing. I've always been under the, I've always been a person who wants to practice medicine for the benefit of the patient and not because of what it pays me. And that has always been my um, mantra, but I think that's why I started off with, if you can get show the administration that it can actually save you some money, then the docs or providers don't have to worry about it so much because you've already got the administration buying into it. It's, you know, particularly some of these other interventions didn't have to be physician driven. They could be driven, you know, you could have a physician as a lead, but other people could be doing it, nurses, medical assistants, whomever. So again, I refer you to the Institute on Health Improvement because I think they address some of the issues around how you can make this worthwhile, unfortunately, for the administration. It's not great.
Another comment was, it's not fair to make people have to go without services in an assisted living facility setting. Somehow it seems that some sort of clarification should be done. What resources would someone use to get services to a patient in an ALF setting?
Yeah. So we're working on that in Bozeman, and actually Jen Crum, who I think is on the call, and I are going to talk about who's allowed to go in different facilities. It really varies from facility to facility, and I think it's got to be a one-on-one conversation with the facility. You know, some of our facilities are owned by corporate entities, and they really restrict who can come in and who can't, based on a global thing. So I think that's really difficult. I think there's no question that getting in these other services is of benefit to patients. It decreases their depression, their delirium, and may even decrease their dying. We really believe in hospice that some people are dying because they're not having these interactions. So I think it's going to be a one-on-one kind of conversation with the different facilities, which is what we're trying to do in Bozeman. They are now doing a lot more communal dining, with some restrictions in most of the facilities in Bozeman, which is great.
All right. Well, thank you, Kathryn. We're right at 1 o'clock now, so I think we'll wrap up, and we will send out the presentation slides and the audio recording to all of you that have registered. Please take time to take the survey at the end. I will also be sending an email with Kathryn's information on there as well. So if you want to reach out to her for further questions, we can do that as well. I think that's it. Kathryn, you have anything else to say?
No, but thank you all for listening. It's actually, it is a really exciting field, I think, and I think there are a lot of opportunities. Don't take on too much. Pick one thing, and I'm happy to have my brain picked also about it. So.
Excellent. All right. Well, I'd like to thank Riverstone Health again and Linda Rohrs for connecting us, also the Geriatric Education Center and GWEP. Thank you all.
Thanks, everybody.